endowed lecture. Our lecture today is Spirituality in Palliative Care, Global Perspectives, being delivered today by Professor Joris Gielen, who is Director of the Center for Global Health Ethics and Associate Professor at the McNulty College and Graduate School of Liberal Arts at Duquesne University in Pittsburgh. My name is David John Dukas, and I am the Director and Professor of Humanities and Ethics and Medicine here at Tulane University, named after James A. Knight. And my job today is to just do the quick introduction and to acknowledge the generosity of the J.R. Williams Endowed Lecture Fund from the Williams family. This lecture fund was initiated in the fall of 2013. The main pointed desire was to deliver lectures in spirituality and health at Tulane School of Medicine, but also in ethics and humanities, focusing on the art of creating a compassionate and trusting relationship between patient and doctor. It honors the legacy of J. Richard Williams Sr., Tulane University graduate, who was a well-known and well-loved internist and oncologist in Selma, Alabama. Dr. Williams was acknowledged as a person who loved medicine and was the kind of doctor who would do anything for his patient, and who had an interest in the impact of spirituality on health, particularly on the positive impact of spirituality on the well-being and continued health of those who have suffered the loss of a loved one. I would also be remiss to not discuss the other co-sponsor of this talk. That is the Master of Science in Bioethics and Medical Humanities. We are on the web at tulane.edu/bioethics, and you can also find us on YouTube if you put in the search term of Tulane and bioethics. We have an Master of Science curriculum with 2 tracks. One is the bioethics track, looking at teaching, research, and service through hospital ethics committees, IRBs, and teaching in all healthcare settings, and the conducting of normative empirical research in healthcare issues. And there is a medical humanities track focusing on teaching or research on those aspects of narrative, reflective writing, fine arts, and history as applies to healthcare. So we have a 1 or 2 year Master of Science program, which is also flexible as a more drawn out thing as a faculty development option for mid-career professionals. We also have a dual degree MD/MS program that is 4 years in duration. So when here at Tulane, you go through the 4-year curriculum and the MS coursework is interdigitated into the curriculum. There's also 3 different 12-hour certificates in clinical ethics, research ethics, and medical humanities. And by the way, these are stackable so that if you took them in sequence, you would ultimately get your way towards that MS degree. If you have any desire to find out more, the web link, as I told you below, is at the bottom of this slide. But there's also the handy dandy QR code that if you take your cell phone camera and point it at this QR code, it will take you right to our website. For contact information, I welcome opportunities for you to contact Dr. Stephen Hansen, Director of Graduate Studies, and Dr. Zofit Affengenden, who's the Assistant Director of Graduate Studies, and you have their emails there. So I'd like to do the introduction now for Professor Gielen. Professor Gielen, as I said, is the Director and Associate Professor at the Center for Global Health Ethics In his research, Professor Gielen focuses on religion and ethics in palliative care from a global perspective. He studies the influence of religion and spirituality on medical decision-making in palliative care, with a special area of interest on the experiences of palliative care patients, their family members, physicians, and nurses in North India. Professor Gielen received his MA in history from the University of Leuven in Belgium, an MA in religious studies, same place. 1 year later, a MA in theology, University of Leuven as well, 2003, then an MA in Indian philosophy and religion at Banaras Hindu University in India in 2005, and then completed his dissertation, an STD, in theology at the University of Leuven in 2010. His doctoral dissertation was on palliative care physicians and nurses, ethical attitudes, and religious beliefs at the end of life in Flanders in Belgium and New Delhi in India. So the title for today's presentation is Spirituality in Palliative Care, Global Perspectives, in which Professor Gielen looks at spirituality in palliative care from a global perspective that integrates the experiences of all stakeholders. A reminder again, for those of you who just have joined us, if you go to the chat, any person seeking CME credit can have their name listed in the spreadsheet that is posted in the chat box. Further, when we do the Q&A session at the end of this presentation, we will do that by means of using the chat, so we were able to go ahead and fairly distribute the questions from all persons. I'll stop sharing, and Professor Gielen, you're up.
All right. Thank you, Dr. Dukas, for this very nice introduction. And it's really a pleasure and an honor to be here, because my research, I feel, very nicely aligns with the mission of this lecture series. I'm going to share my screen. And now you should be able to see the to see my slides in the presentation mode, so not in the editing mode. Now, the title of my presentation, as Dr. Dukas already said, is Spirituality and Palliative Care: Global Perspectives. And in this title, the word "global" is very important, and it's a term that I personally like very much. It's also in the name of our center, the Center for Global Health Ethics, and the word global has a double meaning, and that's of course why I like it so much. The first meaning is, of course, global means, you could say, worldwide. It concerns the whole globe. It concerns everyone, everywhere. So when you're taking a global perspective, that means we're looking at the phenomenon from a global perspective, from the perspective that encompasses the entire world. But global also means, in a way, encompassing. When you're taking a global perspective, you're taking a perspective that encompasses all components of that phenomenon. And that, in the context of healthcare, that of course means that you are considering everyone involved, all stakeholders, but it also means that you're considering the connections between your phenomenon that you study and the wider environment. And that's what I'm going to try to do in this lecture. So I'm going to look at the issue of spirituality and palliative care from a global perspective. That means I'm going to look at it from a perspective that integrates experiences from people all over the world. And in my narrative, I'm going to focus primarily on India and Belgium to illustrate the global impact of spirituality. But global also means that I'm going to look at it from the perspective of everyone involved in healthcare. I'm going to look at the perspective of patients, but I'm also going to look at it from the perspective of palliative care professionals. And Spirituality is, of course, important for all healthcare professionals, but as we will see, it has a particular meaning within palliative care. So for your disclosure, so unfortunately, I have no relevant financial relationships to disclose here. Some of my research has focused on the development of a palliative care distress scale, which can be used in research, but that is publicly available for free. So there's no conflict of interest there. Those of you who have had the opportunity to travel in Europe may have noticed that when you are walking through European cities, you may be walking through a street that looks utterly modern, but suddenly you may come across a remnant from the past. And you can see that, of course, on the structure of the building, but very often it's not clear why that structure is there and what the meaning of that structure is. Sometimes you can see what the meaning is now. For instance, it may be a gate now, but you can wonder what was it in the past. Now it may be a gate to a church, but has it always been a gate to a church? And this picture here illustrates this a little bit. This gate can be found in the town of Leuven, and Leuven is a small university town. Well, it's a university town from where I got my degree. It's a town near Brussels, and it's an historical town as well. And this gate is called the Roman Gate, named after the style, a Roman style, and it dates back to medieval times. Now, in medieval times, this gate used to be an entrance to what was called a hospice or a hospital. Now it's a gate to a church, but in those old days it used to be the entrance to that old hospice or hospital. And that was a place where religious sisters for centuries used to care for the sick, but also for the travelers. And travelers could be various kinds of people. It could be people who are on business trips, but it could also be people who are on pilgrimage. And actually Leuven was also on that clusters of roads that were leading to these important pilgrimage sites in Europe, such as Rome and Santiago de Compostela. So this gate, in fact, illustrates a little bit the history or the religious roots, you could say, of medicine, because this was a place where religious sisters used to care for people, many of whom were not just sick, but who were also pursuing religious goals. They were on a pilgrimage. So in a way, this gate illustrates the importance of religion for both the caregivers as well as the care receivers. Now, one thing that is also nice to know is that you cannot see that on this picture, but this was also actually the place where for centuries the university hospital stood. So that original hospice or hospital developed later onwards into a university hospital. And the last buildings of that university hospital were actually only demolished the past couple of years because the university hospital got a new campus. Now, in a way, these ancient religious hospices were predecessors to what we now call the hospices in our healthcare, because we have hospices and we have hospice care and we have palliative care. And palliative care, in a way, as we know it now, you could say, is an evolution from this hospice care. Now, I guess all of you will have an idea of what palliative care is, but it may be a good idea to start this lecture with referring to the well-known definition of palliative care by the World Health Organization. And as per the World Health Organization, palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. So, and what interests us, of course, here is that word spiritual, because what this definition really illustrates is that palliative care and related hospice care is really an interdisciplinary approach to pain and symptom management. And it looks at that whole range of symptoms and pain and suffering that patients experience. And that includes spiritual pain, attention to spiritual distress and spiritual challenges that patients may be experiencing. So this definition points our attention towards the importance of religion and spirituality for mainly for the patients. Now, spirituality, of course, is not just important for patients, it's also important for healthcare professionals themselves. And one person who was very much aware of that, and you could even say who was not just aware of that, but really was motivated and inspired by religion and spirituality itself, is this lady here. Shown here in her final years. This is a picture of Cicely Saunders, who lived from 1918 till 2005, and as most of you will know, she is the founder. She's considered one of the founders of the modern hospice movement that later evolved into palliative care. Now, important to know is that she herself, as I already said, was in fact very religious, and she considered herself very religious and very spiritual as well. And she was really motivated and inspired by her religious beliefs. And many people know, of course, that religion and spirituality is important in palliative care, but it's less well known that indeed palliative care has a very important, very substantial religious roots. And that becomes clear when we look at the writings that Cicely Saunders herself wrote at the time she was developing these ideas of hospice and palliative care. Important to know is that Cicely Saunders developed these ideas about palliative care in the years after the Second World War. So she started reflecting upon these from the late 1940s through the 1950s. And in 1960, this is what she wrote in a letter to one of the people in which she confided to discuss her ideas, her developing ideas about hospice care and how she could help these dying and suffering patients. And this quote really very nicely summarizes her thought. Because Cicely Saunders writes, "In this work, the medical and the spiritual are inextricably mingled. I long to bring patients to know the Lord and to do something towards helping many of them to hear of Him before they die, but I also long to raise standards of terminal care throughout the country." So this quote is important because it illustrates how spirituality, in Cicely Saunders' view, is important for both the patients as well as the healthcare professionals, because she talks in this quote about her own inspiration. So she says what she actually wants is patients to know the Lord. So she wants them to know that there's a God who cares for them, because she believes that's important to them. So she talks both about her own mission as well as the impact that religion and spirituality can have on the patient. She believes that, of course, to be a very beneficial impact. Now, what she also says, of course, in this statement, and that is equally important, is that she attempted to combine this scientific approach towards pain and symptom management with her own loving care for these patients. Now, what we also see in this statement, of course, is that Cicely Saunders is very mission-driven. So she talks about familiarizing people with her view on God and who God is and how God cares. Now, expressing this kind of views was not very problematic in Great Britain in the 1950s and early 1960s, because at that time Britain was still a majority Christian country. Now, of course, since then society has changed, and we'll talk about that in a minute. But as you also know, palliative care itself has changed as well. So palliative care, in sociological research, palliative care is said to have become secular. So palliative care, as I have explained, started from this very important religious inspiration, but then gradually it became more of a secular movement. And we see that in many aspects of palliative care. For instance, Cicely Saunders, when she was thinking about her ideas of how to develop palliative care, she spoke about how maybe palliative care should actually be developed by a dedicated religious community. And of course, she left that idea behind. Now, palliative care is a professional medical service, which is delivered by people who are specifically trained in that medicine, in that specialization. We also see that secularization in a way in the provision of spiritual care itself, because what you saw in the previous quote is that Cicely Saunders, when she talked about spiritual care, she was talking about spiritual care that was driven by her own mission, by her own desire to talk about the Lord. Now, what we see when we talk about spiritual care is something that is much more scientific, something that follows the medical paradigm. We talk about measuring spirituality and measuring spiritual distress. We also are talking about tools to provide spiritual care. And we sometimes even talk about spiritual interventions. So in that sense, what we see is that to some extent, not entirely, palliative care has become more secular. Doesn't mean that spirituality no longer is important. That we will illustrate in a minute. Now, it's not, of course, just palliative care that has changed. Society has radically changed as well. And Great Britain itself has become a very secular country. And we also see that all over Europe. We also see that here in the US, but especially Europe has become very, very, very secular. And we also see that, for instance, in Belgium, where there is really, some people are talking about an implosion of faith and religion. Doesn't mean that there's no more spirituality, but when we're talking about religion and church attendance, society has become much secular. Now, there is also a second way in which the context has changed for palliative care. As I just told you, palliative care started in the United Kingdom, or the modern palliative care movement started in the United Kingdom in the 1950s. Now, from there and from then, palliative care has spread all over the world. And you see that on this map. This map here shows different levels of palliative care development. And there are two things that are important here on this map. The first thing is, of course, what we immediately see is there's a lot of different colors, and that indicates that the level of development of palliative care is not the same everywhere in the world. It's a little bit obvious, of course. Some countries, such as the United States and Western Europe, are far ahead in the sense that palliative care services are well integrated in the healthcare system, and many people in the healthcare system know about palliative care, and they also know when to refer patients to palliative care services. This is, of course, not the situation everywhere. But what you see is that, in fact, on this map, there are very few countries that have no palliative care services at all, or that are colored in gray here. So you see that palliative care has spread all over Europe, to Asia, Africa, the Americas, and Australia. So this also means that palliative care has spread to contexts in this world, to countries that are culturally, religiously, spiritually entirely different from the United Kingdom. And one of the countries that I'm going to talk about is India. And you see here on this map that in India, indeed, there are palliative care services. So what I have here is a photo of the Ambedkar Institute Rotary Cancer Hospital in New Delhi. And this is a hospital that's part of the All India Institute of Medical Sciences. that is the most well-known teaching and research hospital in India. And I'm showing you this picture again for two reasons. Well, one of them is that this hospital, this cancer hospital, has dedicated palliative care services. They have a palliative care unit, but they also have a pain clinic, and it's also I've been over the past 20 years almost. I've been collaborating with people in this hospital on various projects related to spirituality, ethics, and patients' experiences. Since I'm going to talk a little bit more about palliative care in India and in religion and spirituality there, I think it's helpful for you to have a little bit background on palliative care in India. As I already said, palliative care has not gone through equal levels of development everywhere in the world. So we also see that in India. So by now, palliative care in India is almost 40 years old. It was introduced in India in the second half of the 1980s. And we have palliative care programs basically in more or less every Indian state. So there are a few states, I think, that don't have palliative care programs, but most have palliative care programs. Now, most of these programs, they focus on cancer patients, although in recent years, there has been an effort to expand the scope of palliative care and also extend it, for instance, to patients needing patients with kidney disease, Alzheimer patients, patients with HIV/AIDS, so all these different patients groups. Now, the main challenge for palliative care in India is that the coverage of palliative care is very limited. So if you are living in a big city like New Delhi or Mumbai, you may have access to palliative care services. I say you may. That means these palliative care services are available. They're not sufficient to cover the entire population of these cities, but at least there are palliative care services. If you're living in more rural areas or small towns, then you're out of luck. Then it's unlikely you will actually have access to palliative care. So palliative care there in India is provided by different programs. So you have it's provided at home by palliative care home care teams. There are certain programs that rely a lot on volunteers and combine volunteers with professional services. You have there are hospices, there are pain clinics, there are also palliative care units in hospitals. Important to know is also in India that it's not necessarily the rich who are having access to palliative care. The rich tend to go to the corporate hospitals, and the corporate hospitals have actually been slow to pick up palliative care, because initially they thought that that there's not much money to make with palliative care. Now, gradually, the attitude towards palliative care is changing in the corporate world as well. But what we see is when you look outside these corporate hospitals, the charges made to patients for palliative care are actually limited. And these palliative care programs are trying to rely on various sources of funding, government funding, charity, this kind of things. But they try to limit the cost to the patients. Now, so far I have tried to depict the global context of palliative care. So the global context in which palliative care has been developing. So let us now have a look at what this means for religion and spirituality. And in order to illustrate this global the global role of spirituality in palliative care, I'm going to talk a little bit about ethics and ethical attitudes and how religion and spirituality influence these attitudes. And you will see that religion and spirituality is actually a very complex phenomenon that influences these attitudes in different ways in different contexts. So religion and spirituality, it's not a one-directional phenomenon. It's a very complicated phenomenon, and it can steer people in different directions. And that we actually also see when we're talking about attitudes toward treatment decisions in advanced disease. So in palliative care, of course, Very often difficult decisions have to be made at the end of life, and we can divide these treatment decisions in various groups. So we have certain treatments related to foregoing of curative and or life-sustaining treatment, and then we're talking about, for instance, the refusal of treatment or a decision to withdraw or withhold a certain treatment. We're also talking about decisions related to pain and symptom control. For instance, we talk about intensive pain control, or we're talking about palliative sedation. And then we're also talking about euthanasia and assisted suicide. And it's this last group of treatment decisions that I'm going to talk about a little bit more, because this is the group of treatment where we very clearly see that influence of religion and spirituality, and also the complexity of this influence. So as we go along, I want to make very clear what actually I'm talking about when I'm talking about euthanasia, because sometimes euthanasia is presented in a very broad way. And then people talk about direct, indirect, active and passive euthanasia. That's not how I'm going to use these terms. When I'm going to talk about euthanasia, I'm going to talk about it in a very strict and narrow sense. When I'm talking about voluntary euthanasia, when I'm talking about in euthanasia, it's important to know, can it be either voluntary or non-voluntary? So voluntary euthanasia is basically when the patient has requested it. So voluntary euthanasia is the intentional administration of lethal drugs in order to painlessly terminate the life of a patient suffering from an incurable condition deemed unbearable by the patient at this patient's request. So it's a patient who is suffering and who deems his or her condition unbearable and requests for lethal drugs. And that drug is then administered by a healthcare professional. Non-voluntary euthanasia is the other opposite, is the intentional administration of lethal drugs in order to painlessly terminate the life of a patient suffering from an incurable condition deemed unbearable, not at this patient's request. So there's been no request by the patient, and still we're giving these drugs. That's of course even more problematic than voluntary euthanasia, because many people would argue if you're administrating the drugs without the patient's permission, I mean, there's no question you're basically murdering the patient. And it's even worse, of course, if the patient has explicitly said that he or she would not want euthanasia. Some people would call that involuntary euthanasia. And then there is also yes, I'm sorry. We have a question. Yeah, Juana Costa. Yes.
Yeah. How are you? I just have a question. You said when the patient is just uncomfortable, but is it increased burden? I mean, do you have to have a little more than just not feeling comfortable with my disease process, or is it just something that's going to be futile, and the patient is suffering and is burdensome on them and the family?
You mean for the euthanasia request in order to be approved? Yeah, so that's a very good question. Now, that's also going to depend, of course, on the context. That's the interpretation of that word unbearable, and what kind of conditions would permit euthanasia. That's going to depend on the country that you're in. For instance, in Belgium and the Netherlands, there are elaborate discussions on what exactly constitutes unbearable suffering. So that's indeed something that needs to be clarified, and that's also something where these different euthanasia laws are actually struggling with. For which kind of conditions do we actually permit euthanasia or assisted suicide?
Thank you.
Yes, so very good question. So when we're talking about assisted suicide, that's more the kind of thing that is allowed here in different states in the United States. We're talking about intentionally assisting a person at this person's request to terminate his or her life. So a person gets a prescription, and then the person can take these drugs him or herself. Now, when we are talking about attitudes towards euthanasia, there are various factors that could influence these various attitudes. I'm not going to review all of these. Some studies have shown that age, for instance, influences these attitudes, with sometimes older people being more reluctant, Or some studies have shown, for instance, gender to be a factor, with women sometimes being more reluctant to approve of of euthanasia and assisted suicide than men. Other studies have, for instance, shown that country is a factor where you have countries in which euthanasia and assisted suicide are ethically permissible being more lenient, in which, for instance, physicians and nurses in which euthanasia and suicide is permissible, that these physicians are more likely to actually approve of euthanasia. Now, one factor that often comes back is the factor religion. So there are several studies, many studies actually, that have shown that religion is a factor that influences attitudes towards euthanasia and assisted suicide. Now, I know that the title of this lecture was that spirituality was in the title and not religion, but and I do know that these are different concepts. The distinctions are a little bit complicated, but what we also know is that there is some kind of overlap between these, and that's why I'm talking about religion now. So I don't argue that religion and spirituality are the same, but there is some overlap. So when we're talking about spirituality, automatically to some extent we'll be talking about religion as well. So several years ago, we did a study on the influence of religion and worldview on the attitudes of euthanasia, of palliative care nurses in Belgium, and what we found, in fact, illustrates this complicated influence of religion, and you could also say spirituality, on these attitudes. Because first of all, what our study did find is indeed that there is an influence of religion, in the sense that what you see here, when you look at the various groups in our survey, because you see here that we divided these participants in different groups. We had atheists, we had doubters, we had church-going, we had religious but not church-going, and then we had devout church-going participants. When you look at the atheists, you see that they were much more likely to be staunch advocates, and then less atheists were moderate advocates, and then even less were moderate opponents. When we look at the church-going participants, we see a very different picture. We see here that they were less likely to be staunch advocates and more likely to be more moderate advocates and even moderate opponents. When you look at the group of the opponents, we see that those who are church-going and devout were labeled as church-going and devout church-going, that they were most likely to actually oppose these practices. Now, I already said that this graph in fact illustrates the complexity of religion, and that we also see here, because what we see here, for instance, when we look at these church-going opponents, we see that although they were less likely to be staunch advocates, they were not necessarily radically opposed to the practice. So we see here that many of them were actually also moderate advocates, and many of them were labeled as moderate opponents because their opposition to euthanasia and assisted suicide was not total. And this is, of course, also related to the complex context of palliative care in Belgium, where euthanasia and assisted suicide are allowed. So these palliative care physicians and nurses indeed also know that euthanasia is actually a possibility, and that many patients may actually request it and they may legally be entitled to it. So for these physicians and nurses, it seems it's more difficult to actually radically oppose this practice because they don't want to leave their patients alone in the end, even if they are religious and even if they're not entirely comfortable with the practice themselves because of religious and spiritual reasons. Now, when we're talking about palliative care in Belgium, we are talking about a group of people, physicians, nurses, who are primarily Christian still. There has been a lot of secularization, I already told you about that, but still many people still somehow identify with Christianity, and either many of them are Roman Catholics in Belgium, or minority belongs to another Christian denomination. But we see that people with no religious or ideological community or non-religious ideological communities, that these people are a minority. That is, of course, very different when we are going to look to a country such as India. In India, of course, the religious landscape is very different. In India, the majority of the people, around 80%, if I'm not mistaken, is Hindu. So Hinduism is the majority religion there, and Hinduism has very different religious beliefs. And one of these religious beliefs that you may have heard about is the belief in karma. Karma is the belief that every deed will have a consequence. So if you do good, then you will receive good. If you do bad, you will receive bad. Now, in Hindu belief, that belief in karma is related to the belief in rebirth, because it is said that you can experience the consequences of your acts across births or across different births. So if you do good in this life, you will not necessarily receive good in this life. You may receive that good in the next life. Likewise, if you do bad, you may receive the bad consequences in this life, but you may also experience them. You may also experience them in the next life. So, for many Westerners who think about the idea of rebirth, rebirth is something that is nice because they think like, well, I've had a lot of fun in this life, so if I get reborn, then I will have a lot of fun in the next life, as well. But for Hindus, it's a little bit more complicated. On the one hand, they see that rebirth offers opportunities in the sense that you can always improve your destiny. So if you mess up this life, I mean, you will not be doomed for eternity. You will have actually an opportunity to do better. But on the other hand, there's also this idea that life is not just about having fun and enjoying. There's also a lot of suffering in this life, and there's also dying in this life, and we all experience this kind of things. Even if we have a very good, fulfilling life, in the end, we all die, and we see other people die. So there's always pain and suffering. So ideally, Hindus want the cycle of death and rebirth to end. Now, this is just a newspaper clipping to show that indeed people sometimes think about their own life in terms of karma, and about the things that they experience in terms of karma. For instance, this guy here, he had been driving drunk, and while driving under influence, he had killed 5 people. Now, what he argued was, well, what I did was actually, I mean, I'm not a bad person. I should not have done this, but maybe I did something wrong in a previous life, and because of that, I'm now suffering the consequence of that. But as such, I'm a good person. Well, ultimately, the judge, of course, didn't buy that, and he did get 5 years in jail for killing these 5 people. But what you will also see or understand is that this belief in karma, that it can actually have a consequence on how people and healthcare professionals think about euthanasia, for instance. And how people in palliative care think about this. Because people may argue that euthanasia and assisted suicide may, in Hinduism, not be allowed because they may result in bad karma for the physician. You could say, well, the physician is killing someone, so that's going to result in bad karma. Or other people would say, well, it's actually not going to help the patient, because if you kill a suffering patient, that patient can actually not purify his or her own karma. So then he or she will have to suffer these bad consequences in a next life if he doesn't go through that purifying experience of suffering in this life. So some people have argued that in this sense, Hinduism is fatalistic, in the sense that if you do something, you must experience the consequences, and you will never be able to escape your fate. But this is not necessarily how Hindus themselves see it, and this is also not how Mahatma Gandhi saw it. Because Mahatma Gandhi, in his works, he reflected a lot about life, but he reflected a lot about violence as well. And in that context, he also reflected upon under what circumstances may it actually be permissible to kill a person. And then he was also asked this question: what kind of circumstances may be permissible to actually kill a patient, or would it be permissible for a patient to kill herself? And once he got that question from the brother of a patient who had been considering killing herself, but ultimately this lady, she had decided against killing herself because she said that her suffering would actually allow her to purify her karma. And then Gandhi actually said this: the question of karma does not arise at all. So if we were to bring in the law of karma in such matters, we would put an end to all effort. The working of karma is an incessant, ever-growing process. And then he goes on, but this is actually the gist of his argument. Karma is incessant, ever-going process. We don't know really how it works and what is a consequence of karma and what not. So if you're ill, is that a consequence of karma? We don't know. We don't know exactly how karma works. And that's also indeed what we see when we look at the attitudes of physicians and nurses in India towards euthanasia. Because I had the opportunity to talk to them about this issue, and when I asked them, well, will it lead to bad karma for the physician? There was actually no unanimity. Some said yes, it will lead to bad karma because it is murder, but others said no, because you're trying to do good. So how can it lead to bad karma? So you see, it's not fatalistic. They don't really know how it exactly works. So this is just a quote to illustrate that point. So when we are looking towards the various arguments in favor of euthanasia and assisted suicide that were given, then many of these arguments were secular arguments, such as putting an end to suffering or saving scarce resources. I mean, it's a little bit hard to understand, of course, in our context, but India is a context where the healthcare resources are limited, and some participants argued, well, if a patient is nearing the end of life and a family is spending a lot of their money on the treatment of that patient, then that's actually going to impact the next generation, so they should consider that. Other people refer to the effect of good palliative care, and they in a sense said, well, no, we have palliative care, so why should we kill patients? Other people said actually that euthanasia may not be allowed because it's actually illegal in India, and others said, well, it may not be allowed because it is killing, and obviously killing is not allowed. But then the question I asked was, well, but why is killing the patient wrong? And then the interesting thing was that the answer I got was this: it did not refer to karma, but it referred to faith in a life-giving God. And this is what these patients said, and what these healthcare professionals said. And this is, of course, very recognizable for people who are Christian, Jews, or Muslims, because they say exactly the same thing. They say, God gives life. Because of that, God can also take it. We cannot take life. Or another one said, no one except God has the right to take away one's life. So what we see is, it's not karma that is going to determine their attitudes, but when there's a religious influence, it's about that faith in God. Now, when we're looking at the how Hindus experience illness and disease, it's indeed that faith in a life-giving God that is very important. And we in fact see that in the pictures of these Hindu gods. These Hindu gods are very powerful. They're very powerful gods in general. And you see that for instance, in this picture, you see that in the weapons that this god has. With these weapons, she can destroy all evil. But at the same time, this god is also a loving god, a caring god, and that you see in this hand movement. So the god is in a sense saying, well, do not be afraid. I'm here to take care of you. So do not be afraid. The same thing we see also, for instance, in the stories about the avatars. And the avatars, well, this is not a Hindu avatar, of course, so this is a bit a misinterpretation, but the word avatar comes from the Hindu religion, and there it means God who comes down from heaven to help human beings. And God comes down whenever human beings need him. And this God is very powerful. And when God comes down to help human beings, he can do everything. And you see that here on this picture of the Lord Krishna. He is here holding a mountain, and he's holding that mountain because one of the gods once had decided to flood a village with very heavy torrential rains. And Krishna rescued that village just by lifting an entire mountain but with his pink. So this illustrates that for God, nothing is impossible. If you pray to God, God will help you, God will be with you. And that's, of course, something that is very important for patients. And patients really rely on that. Patients pray to God and hope that God will support them. And indeed, many studies have shown that all across the world, not just in India, but of course also in the Western context, in the United States, in Belgium, religion and spirituality is important for patients, because they can derive support from religion. They can derive strength. However, religion and spirituality can also be a source of distress, and that happens a lot with these patients in India, because they believe that God is there to help them, that God is very powerful, that God can help them, that God can do anything, God can cure them if he or she really wants. And they pray to God for cure and help. But very often, of course, in the end, all of us are going to die, and these patients also going to die. And that, for many patients in palliative care in India, that is a tremendous source of distress. And that's also what we saw in one of our studies. So we saw here that there are many patients we call trustful patients who still have that belief in God, but we also saw that there were 17% who we called spiritually distressed patients. So patients who are asking this question: what is happening? Why is this happening? We also
Can
see
somebody please mute themselves? They're flowing over onto the conversation here. Thank you.
yeah, I'm also trying to finish so that we still have time for a few questions. So what we also see is that there are patients who are clinging to divine support. So these are patients who are actually saying that, indeed, I still have that faith in God, but I'm also suffering and I'm having pain. So if God wants to help me, it's about time. God should come now. So we see that there is a lot of tension and anxiety in these patients. And what I've listed here, in a sense, is, well, the double role of religion and spirituality. So indeed, many patients have that feeling that God is with them. So we see that a lot of the patients that we study have this feeling. For instance, God is with me, 88% of the feeling, or I have a belief, God is with me, 88% has that feeling, or I have a belief in God which gives me strength. 87% of patients had that feeling. But at the same time, we also see that there's a lot of spiritual distress in this patient. So although many people say that, well, God is with me, many of them also say this illness isn't fair, and this illness is a punishment from God. For instance, 66% said that. So what this what these two graphs actually illustrates are these very strong feelings that patients have about spirituality and religion in India, but then also, of course, worldwide, and how often these feelings and emotions can be contradictory and can cause a lot of distress. And that is, in my work in India with patients there, what indeed I have often seen. They're not fatalistic, but they're waiting for God to help, and many of them indeed have that belief in God, like God will help. But in the end, as the disease progresses, then many of them are feeling that, well, where is God? And why is God not helping me? And why am I not getting better? And there are many patients who have asked me that question, and many of you will have had the same experience, that patients are asking this question: why am I not getting better? Why is God not helping me? So religion and spirituality for some of them, it can indeed be a source of support, but for many of them, for many others, it's a source of distress when the hope for help does not not appear. And in their suffering and in their pain, patients keep on searching for meaning. They keep on searching for support, but also keep on searching for meaning. And when patients in India are searching for meaning, then they come up with this theory such as karma. Well, maybe it's karma. And I have given here the example of one of the patients I worked with, who was a very intelligent guy, very philosophically oriented as well, and he reflected a lot about his life and the meaning of his suffering. And he said, "Well, maybe it's karma. Maybe because of karma. Maybe I've done something wrong. Maybe that's why I'm suffering." But it did not lead to any fatalistic acceptance of his illness, because he also kept on praying to God for a cure, and he keeps on asking for treatment options. So what I've tried to explain throughout this story is, and throughout the examples actually of my research in Belgium and India, is how religion and spirituality really is a very complex phenomenon that can lead people to different perspectives and different experiences, and that this religion is actually not just important for patients, but it also guides, motivates, inspires healthcare professionals, and that's my story.
Excellent. Thank you so much. We're going to get to questions in just a second. I'm going to need to do a couple things. First, for those desiring CME, please see the link in the chat to the CME sign-in sheet. If you're unsuccessful at getting your data put in, or if you're at a site like the VA or elsewhere where they have a firewall stopping you, please email Emily Forfer at eforfer@tulane.edu, and in the subject line put CME, and then enter your name, your degree, and the type of CME, like CEUs or CMEs you'd like. Okay. The other question that I have for Professor Gielen is, will the slides be shared? And if so, can we just send them to Emily, and then we can just distribute them to people, or post them on the website when we put the YouTube video up?
Oh yeah, I will gladly share them.
Okay.
I will send them to Emily, and then she can do with it whatever pleases her.
And I'm going to introduce, as the first person for a question, Dr. Sonia Malhotra, who is also part of our faculty and practices at University Medical Center, and has a unique background that she can share as to its relevance to what you've been speaking at today. Sonia?
Yes, thank you, Dr. Gielen, for this lecture. You know, as a practicing Hindu myself, your lecture is very fascinating. I just recently had a chance to return from India on Wednesday evening, where I did work in global palliative care in Kerala and Karnataka. My question is, and I know this got brought up many times, is the sort of confusion between physician-assisted death, medical aid in dying, euthanasia, which, you know, to me, frankly, was a little bit shocking to hear that term as a palliative care physician myself. Where are your thoughts on that in terms of use of words like euthanasia, physician-assisted suicide? Because in the world of palliative care, we have moved away from that. And how do you think that sort of impacts, sort of religious beliefs, especially since your work is amongst Hindus, and Hinduism and Buddhism share many sort of philosophical similarities. How do you see that playing out in terms of the populations that you are working with?
Yeah, so it's a great and it's a very important issue. This correct use of terms, and particularly in India, you know that in India they still very often use these terms active and passive euthanasia, for instance, in the court case surrounding Aruna Schoenbach, where the courts used these terms active and passive euthanasia. They did not use them very well, and that has led to a lot of confusion. And that indeed, and even the Indian Association of Palliative Care actually has used these terms active and passive, and that is, I believe that and most people, most philosophers will of course agree that's not a good use of these terms, because if you're going to combine having this kind of broad interpretation of euthanasia, it's going to become very difficult to know what exactly you're talking about, because sooner or later you're going to use the term euthanasia, and then it's like, okay, what are you talking about? Are you talking about foregoing treatment, giving a lethal injection, or maybe you're just talking about pain management sometimes, even if you're using direct and indirect. So it's very confusing, and it's indeed very important that we are clear on these terms. And we actually we just did a meta-analysis of attitudes towards euthanasia in India among healthcare professionals, and we're presenting that next week at the conference of the Indian Association of Palliative Care. And one of the things that we also showed is, besides showing like how many people approve of this practices, we also showed that it's indeed difficult to actually make statements because the terms are not used consistently in a clear and direct way. So it's a very important problem.
David Myers has a question. You seem to largely equate spirituality with religiosity, reflected in much of your talk and the survey you just showed. Can you speak to spirituality in realms other than the religious?
So yes, that's a very good question. Now, first of all, what we have seen in our research in India is that a lot of the spiritual experience has a religious component. So that is one thing. So the experience of spirituality has similarities all across the world, but there are also differences when we study them. So that is one thing. Then the second thing, and that is about the difference between religion and spirituality. You will often find in the healthcare literature, and particularly in nursing and palliative care literature, that religion is then described as something that is characterized by set beliefs and set practices, while spirituality is more about meaning. Well, I understand how they come to these definitions, and I absolutely agree that there is a difference between religion and spirituality. But I also have to say that the distinction is much more complicated, or the overlap is much more complicated than these often very short descriptions seem to suggest. There's actually a lot of literature on this in the field of religious studies, but unfortunately, religious studies and sometimes research on spirituality and in palliative care and nursing, they don't communicate very well. So I don't want to equate them, but yeah, it's a complex distinction.
Juan Acosta has his hand up.
Yeah, thank you so much. Thank you so much for a wonderful webinar there. I had a question in regards to how do you convince family member healthcare proxy that if they place the patient on hospice because of suffering, that we're not really doing euthanasia? Because that's one of the questions that keeps coming up. Is like, well, you're going to be giving medicine and it's going to stop them from breathing, and they're not going to feel anything. But it's sort of and it's kind of a situation that they're in reality. I mean, it's true, but we're actually waiting until the end of life, just to make them comfortable and prevent them from suffering further. Yeah, that's a very good question, and that actually also relates to the point that Dr. Malhotra mentioned earlier, how important it is to make this clear distinctions between these various treatment decisions, because when people read on the internet, they often are not able to make this clear distinctions, and then they think that well, you're giving the drug, so you're killing the patient, and that's what they may want, or that's what they may not want.
So it can indeed be very hard to explain that to them. I think what is important is really try to tell them the facts, to give them the facts, and the facts are that you are a very experienced clinician, and that you know what you're doing, and that you also know that when you titrate these drugs properly, that most often there will not be a that hastening effect. So I think education is very important there. But,
We have one last short question from Dr. Malhotra. I do want to remind people that we will be having our next Williams lecture on March 8th at noon time Central. Dr. Jada Wiggleton Little, who is currently the Neuroethics Fellow at the Cleveland Clinic and incoming Assistant Professor of Philosophy at Ohio State, the Ohio State University, we'll be talking on intention versus interpretation. Sonia, I'll give you one last shot. Unmute. There you go. Oh. We've lost sound. Okay. All right. Dr. Gielen, I want to thank you for this excellent presentation and discussion. And I hope you'll be joining us in the audience for future presentations as well. Thank you very much. Take care.
Thank you.
Thank you all.